terminal chop. I'm Dr. Nishant from MNI Hospital, Chennai. So this session is going to be a bit interesting. It's not going to be concentrated only on cataract. So we all know that a cataract with a combination is with all the other specialties. That is, we have talks on cataract with glaucoma, cataract with uvea, cataract with retina. So it is going to be interesting. So let's start. I'd like to call upon Dr. Shruti and Dr. Madan to join me here, please. So apart from the normal way of introducing, we have actually planned a different way. So I'd like to call upon Dr. Aswathy. She's got a great interest in art and music to actually her main profession. And yes, apart from that, she's also a cataract, cornea, and a refractive surgeon from Sunrise Eye Hospital, Kerala. She's going to talk about how important is the ocular surface on a great visual comfort. Over to you.
Thank you, sir, and thank you, AIOS, for giving me this opportunity. When a very experienced cataract surgeon perform a phacoemulsification and give the patient the 6/6 vision, we feel ourselves like an angel, but we may see the satisfaction in patient's face sometimes. The so-called visual comfort may be lacking for the patient. So coming to my topic, bad ocular surface to great visual comfort. Myself, Dr. Aswathy. So do not see the eye, see the patient as a whole. Take the history from the patient regarding the joint pain, thyroid, dry mouth, which points to rheumatoid arthritis, thyroid disease, and Sjogren syndrome. Also use of the long-term use of the ocular medicines, which damage the ocular surface, past history of trauma, ocular surgeries or infection. Do not see the phacoable eye as such, see the ocular surface like the lid, tear film, cornea, conjunctiva, and limbal stem. The ASCRS have given the preoperative ocular and surface disease algorithm. We should see the clinical examination, the LLLP. What is this LLLP? It is look, left, pull, and push. We have to see the blink, see the lid slashes and interpalpable surface, lift to see the upper lid superior surface, and pull to assess the lid laxity, and push to see the meibomian gland expression. So we can see the blepharitis here, which we miss most of the times, and treat them with the warm compression or antibiotics with the lid hygiene. Then opacity in the cornea. Pterygium, it is better to operate the pterygium and wait to see the IOL calculations. Lid marginal keratinization, better to remove this lid marginal keratinization and do the mucous membrane grafting. Conjunctival callosis, early stages we can treat with the topical drops, and later we have to excise it. These are the various stages of the Steven-Johnson syndrome. Then pharyngeal, better reconstruct the fornix and give the amniotic membrane grafting. And lift the eyelid to see if there is any superior limbic keratitis or this filamentary keratitis. Remove this and treat with the topical drops. Lid viper epitheliopathy, or better correct the ectropion and push to see any meibomian gland expression. That is better. Treat before the make the ocular surface healthy. And stain the eye, which we miss most of the things while staining. We'll know the severity of the dry eyes or any other pathologies. And the most important thing is the tear film assessment. If it is less than 0.1 mm, it is called the low, and high if it is greater than 0.2 mm, which indicates the reflex tearing or the deficiency of the nasolacrimal duct. Schirmer test, non-invasive T-butt, osmolarity test, and MM9 test. So why it is important to recognize the subclinical OST before the surgery? The surgery itself is a trauma which releases many inflammatory cytokines and it damages the ocular surface. And why is the tear film important? Between each blink of the healthy tear film, there will be 0.1 diopter difference. So if it is unhealthy, there is more than 1 diopter difference between the blinks, and there will be difference in the calculation. So the challenges we are facing are pre-op biometry for the IOL power calculation, intra-op visibility, increased risk of complications, compromised visual outcome, patient dissatisfaction, post-operative infection and melt. How to optimize the cataract surgery? The most important is diagnose preoperatively and counsel the patient. Address the condition to the patient and tell them that post-operatively we have to deal with this, and stabilize the ocular surface medically or surgically and manage the underlying immune etiology. If there is rheumatic arthritis, just refer to the rheumatologist. So our goals are to reduce the inflammation, resolve the infection, improve epithelial pathology, stabilize the tear film, ease the symptoms before the ophthalmic surgery, and surgery should be delayed until the ocular surface is optimized. The Tear Film and Ocular Surface Society Dry Eye Workshop has given the tiered approach for the treatment. Initially, we can try with the lubricants and non-medical modifications, lifestyle modifications like diet and lifestyle modifications. And then the topical and systemic medications can be given with non-permanent temporary punctal occlusion, expression of the meibomian gland, also the topical immunomodulators and antibiotics. Later we can give the autologous serum, eye drops and therapeutic contact lens, and higher grade we can do the mucous membrane grafts, permanent punctal occlusion and other surgical approaches. The topical drops, the ocular lubricants should be preservative free. We can give the antihistamine, antibiotics like doxycycline, azithromycin, anti-inflammatory to relieve the inflammation or any allergic pathologies. Then immunomodulator, cyclosporin A, Sequa, which is 0.09% cyclosporin, or Restasis, which is a cyclosporin emulsion 0.05%, Lifitegrast 5% solution. Systemic medications like the macrolides, omega-3 fatty acids or tetracyclines. Then procedural therapy, the meibomian gland expression, then punctal occlusion, or this is the intermittent light pulse therapy, this is LipiFlow. And ocular surface reconstruction, PROS, that is prosthetic replacement of the ocular surface to make the ocular surface healthy before the cataract surgery. The IOL selection is very important. Do not choose for the premium IOLs or toric IOLs. They can cause higher order aberrations and reduce contrast sensitivity. So this Procera and Ambiodisc, both are the amniotic membrane graft. That is, Procera is the cryopreserved amniotic membrane graft, and Ambiodisc is the dehydrated amniotic. This can hasten the ocular surface, make the ocular surface healthy before the cataract surgery. So the take-home messages are, the history and clinical examination is very important before the surgery. Counsel the patient, and surgery should be delayed until the ocular surface is optimized. We should not choose the premium IOLs or the toric IOLs. There are challenges in the IOL power calculation, and you can counsel the patient prior. Post-op, we have to use the frequent medications and for the dry eye treatment, and recognize the subclinical OST since the surgical trauma can exacerbate them. Thank you.
Thank you, Dr. Aswathy. So, as she has explained about all the preoperative things, I feel that yes, before they step into the OT, as long as they know that they have an ocular surface disorder, it is much easier to treat, one. And two, I'll say that make sure that you have a small torchlight also in your OP, because it's not only the slit lamp, there are so many findings we would find out with a torchlight evaluation too. And one of the commonest thing is also a conjunctival chalasis, which is being missed most of the times preoperatively. So they come back after a week with 6/6 with being uncooperative, and sometimes just a small knit or just a small cauterization of the conjunctiva also gives them a good satisfaction. So thanks, Dr. Aswathy, for letting us know the importance.